Dr. Vincent Rajkumar, MD, is Professor of Medicine and Consultant, Division of Hematology, Department of Internal Medicine at the Mayo Clinic, USA. After completing his MBBS at CMC Vellore, he went on to do his internal medicine residency at the University of North Dakota School of Medicine and fellowship in hematology and medical oncology at the Mayo Graduate School of Medicine. He is engaged in clinical, epidemiological, and laboratory research in myeloma and related disorders. He served as the principal investigator on several landmark clinical trials for the treatment of myeloma, including the pivotal trial that led to the regulatory approval of thalidomide for the treatment of the disease in the United States. He is the recipient of the Distinguished Investigator Award, Mayo Clinic, for the year 2018. He is currently Editor-in-Chief, Blood Cancer Journal, Associate Editor, European Journal of Hematology, Member, Myeloma Steering Committee, National Cancer Institute, Member of the Board of Directors, International Myeloma Foundation, and Chair, Myeloma Committee, ECOG Akron Cancer Research Group. Dr. Vincent will speak to us today on updates in myeloma management and related syndromes.
Hi, everyone. I'm Vincent Rajkumar. I am from the batch of 1984 at Vellore. And now I'm at the Mayo Clinic in the Division of Hematology. And my research focus is multiple myeloma. Today, I'm really honored to present the multiple myeloma update for you. I'm recording this, but I hope to be live on video to answer any questions and to meet with you on the day of the meeting. I will share my screen now. So again, thanks for inviting me to give this talk on multiple myeloma 2020 update. I have no conflicts of interest to disclose. Before I get started on what's new, I think one of the main things to keep in mind is that the disease definition in terms of what we call multiple myeloma has changed. Prior to 2014, myeloma was defined by the presence or absence of CRAB features. Now, CRAB features was hypercalcemia, renal failure, anemia, or bone disease that are felt related to the plasma cell disorder. Patients who had a clonal plasma cell disorder but did not have CRAB features were considered to have either monoclonal gammopathy of undetermined significance or smoldering multiple myeloma. Now in 2014, the disease definition changed, and the main change was that you do not anymore need symptoms to call multiple myeloma as myeloma. You have either the 4 CRAB features or 3 myeloma defining events, which are biomarkers, more than 60% clonal plasma cells in the bone marrow, more than 100 for the free light chain ratio, or more than 1 focal lesion on MRI will all qualify as multiple myeloma, regardless of the presence or absence of CRAB and regardless of the presence or absence of symptoms. And this was published in the Lancet Oncology in 2014. I was privileged to lead this initiative with over 200 members of the International Myeloma Working Group. The second important concept that I'm now involved with is to reconsider myeloma from being one disease into multiple diseases. So my colleague, Dr. Shaji Kumar, and I wrote a paper called The Multiple Myelomas, plural, in Nature Reviews and Clinical Oncology last year. And that is because myeloma really is at least 6 different types. And that's shown on the top half of these 2 panels. Half of the myelomas that we see have trisomies. These are extra copies of chromosomes 1, 3, 5, 7, the odd numbered chromosomes. The other half have translocations involving the immunoglobulin heavy chain region located on chromosome 14, Q32. And this would be patients with 414, 1114, 614, 1416, or 1420. So you have these 5 recurrent immunoglobulin heavy chain translocations. So overall, those 5 comprise about half the patients with myeloma. And so you really have about 6 types of non-overlapping entities with multiple myeloma. Each of these 6 types of myeloma can be complicated by secondary cytogenetic abnormalities, such as deletion 17p or gain 1q. And so you really have a more complex picture coming into place. About 25% of patients with myeloma have what we call high risk disease, and 75% have what we call standard risk multiple myeloma. Now at the Mayo Clinic, we have further refined this to consider patients with 2 high risk features as double hit myeloma and 3 or more high risk features as triple hit myeloma. And we know now that the prognosis worsens when you have double hit and further worsens when you have triple hit disease. And therefore, this classification is important when we counsel patients as well as for management decisions. Now, initial therapy of myeloma, there are a number of randomized controlled trials that one can look at, but really there's only a few that really impact practice in 2020. Number one is the SWOG trial that was published by Dr. Brian Dury in Lancet. And this looked at bortezomib, lenalidomide, dexamethasone versus lenalidomide and dexamethasone. In this trial, bortezomib lendex or lendex was given for only 6 months. And then after that, both arms, patients got only lendex doublet. This trial really changed clinical practice and has established the standard of care for the disease. You can see here a significant improvement in progression-free survival by the use of VRD over RD, a progression-free survival of 43 months, which means that if you start a patient today on VRD in 2020, they could go 4 years before they need the second-line therapy. And overall survival also was significantly better, 6 years with VRD versus 64 months or 5 years with RD. And VRD really became standard of care across the world based on this study. Now, we are always not satisfied until we cure the disease, and we are always trying to improve on this. And one way to improve on VRD would be to change the proteasome inhibitor and use a monoclonal antibody instead. So daratumumab is an anti-CD38 monoclonal antibody, and a trial which looked at Dara Lendex versus Lendex has been published. It's the Mayo trial. And just like we saw with VRD, the triplet using daratumumab Lendex is better than the doublet of Lendex with significant improvement in progression-free survival. So this is an alternative to VRD. The reason I still prefer VRD is because in the VRD regimen, you're using a triplet only for 6 months, and then you're only on lenalidomide. On the other hand, with the daratumumab Lendex regimen, you have to use the triplet for a very long time. In a country like India, that would be extraordinarily expensive to use in the frontline setting. So VRD is still my default standard. The other way to improve on VRD is to change the proteasome inhibitor and use carfilzomib instead of bortezomib. And we have done this trial. My colleague, Dr. Rajkumar at Mayo led this trial. I was happy to lead this with him in ECOG. We just published this in the Lancet Oncology. It's over 1,100 patients randomized to VRD versus KRD. And we found no benefit by using carfilzomib instead of bortezomib in this trial, either in progression-free survival or in overall survival. Now, carfilzomib may still have a role in patients with certain high-risk disease patients who were excluded from this trial, but that remains to be proven. Finally, the other way of improving on VRD would be not just substituting a drug, but adding a drug. So instead of VRD, you use 4 drugs instead of 3. And in France, they tested this concept. They didn't use VRD, but they used VTD, which is bortezomib, thalidomide, dexamethasone. And they showed that by adding 4th drug, you improve progression-free survival and possibly even overall survival. Now, we need more data like this with VRD before we can embrace a 4-drug regimen, particularly given the extra cost and the extra toxicity. What is the role of autologous stem cell transplant, which is a mainstay of myeloma therapy, in patients who are being treated with new regimens such as VRD? The IFM trial looked at this. The IFM trial looked at patients with VRD plus early transplant versus ERD with delayed transplant. And what we find is that VRD adds to, we find that transplant adds to the VRD regimen by progression-free survival. However, if you're going to do transplant anyway, whether you do it early or late does not seem to matter for overall survival. So overall survival is still identical in this trial with early or with delayed transplant. So again, you need transplant. This trial did not study transplant versus no transplant. But if the question is when to do the transplant, the timing, early or delayed, does not seem to matter for overall survival. There is an update to this trial that's going to be presented at ASH this year. And the early abstract shows that at 8 years of follow-up, the overall survival is still identical between early and delayed transplants. So particularly with COVID raging in many countries, I think for standard risk patients, a delayed transplant approach is entirely reasonable, safer, and shows that we don't really lose anything in terms of overall survival. All patients with myeloma relapse, and therefore lenalidomide is used as maintenance. A meta-analysis of randomized trials shows that lenalidomide maintenance improves progression-free survival and also improves overall survival. So we use this routinely in our practice. Our algorithm at Mayo for the treatment of newly diagnosed myeloma looks like this. For standard risk patients, we do VRD, and then we can either do early transplant and len maintenance, or we can collect stem cells for future and then do a few more cycles of VRD and len maintenance, reserving stem cell transplant for relapse. Either approach we know now gives you the same type of overall survival. On the other hand, for high-risk patients, you could use VRD or even a quadruplet, but prefer early transplant rather than early or delayed. And for the maintenance is where the real change occurs. In high-risk patients, based on the HOVON trial, we prefer bortezomib-based maintenance. And when I say bortezomib-based, what I mean is bortezomib plus lenalidomide rather than lenalidomide alone. In transplant-ineligible patients, the algorithm is somewhat similar. For standard risk patients, we do bortezomib lendex for about 6 months, followed by len maintenance. For high-risk patients, bortezomib lendex for about 6 months, followed by bortezomib-based maintenance, that is bortezomib plus lenalidomide. In standard risk patients, dara lendex is an option, but as I told you, that's going to be extraordinarily expensive, and there's no data that it's going to be better than VRD. What do we do for relapse disease? For relapse disease, we have many options. We have several drugs that have been approved since 2013, and I won't go through them in detail. Suffice to say that carfilzomib and ixazomib are proteasome inhibitors. Pomalidomide is an analog of lenalidomide and thalidomide. It is an immunomodulatory drug. Daratumumab and isatuximab are anti-CD38 monoclonal antibodies. Panobinostat, HDAC inhibitor. Elotuzumab, a monoclonal antibody against SLAMF7. Selinexor, an XPO1 inhibitor. And belantamab, the newest drug, which is an anti-BCMA antibody drug conjugate. Now, how efficiently we use these new drugs is what causes improvement in progression-free and overall survival for our myeloma patients. The selection of regimen, I think it's more important to know the principles rather than the various regimens that are available. The 4 important factors that govern the choice of therapy are the timing of relapse, the response to prior therapy, the aggressiveness of the relapse, and the performance status of the patient. At first relapse, we don't have head-to-head comparisons of the various combinations that have been tested, but clearly daratumumab-based regimens seem to have a better reduction in the risk of progression compared to other regimens. Therefore, For patients in first relapse, my algorithm looks something like this. It depends on whether the patients are refractory to lenalidomide or not. And if the patient's not had a transplant, you always want to consider a transplant first before you look at other regimens. But let's say the patient's not transplant eligible or has already had a transplant. Then if the patients are not refractory to lenalidomide, then dara-lendex is my go-to, with these being alternatives. And if the patient is refractory to lenalidomide, then dara-bortezomib dex or dara-pom dex is an alternate, is my preferred regimen. Clearly, cost comes into play, and daratumumab at present in India is very expensive. So you may find that alternative regimens that I've given here are more useful for your situation than what I have highlighted. For example, bortezomib cyclodex, carfilzomib pomdex, or carfilzomib cyclodex may all be reasonable options. For patients refractory to lenalidomide, there have been a series of trials which have shown that pomalidomide-based regimens are useful. Now, in the US, pomalidomide costs $17,000, $18,000 a month, but in India, it only costs a few $100s a month. So POM-based regimens are really useful in India, but I've heard that you have more toxicity in India with pomalidomide and lenalidomide. And I think it's mainly because of the dosing. I recommend only a very small dose of lenalidomide in patients of Asian descent. Even 10 or 15 milligrams may be enough. And pomalidomide is the same story. You may have to give only 2 weeks of 2 milligrams rather than the 3-week 4 milligrams that we use. Pomalidomide-based regimens have been tried with elotuzumab, with isatuximab, and carfilzomib, as well as with daratumumab. So they're really good options. And given POM is not that expensive, they become very good, important options for you in patients who are refractory to lenalidomide. The principles are more important, which is at every relapse, you want to use at least 2 new drugs. You want to use a triplet. And since DEX stays the same, it's really changing the other 2. And always consider clinical trials, and always consider transplant ineligible patients. For second or higher relapse, any of the first relapse options I mentioned could be tried, as long as the patient's not refractory to them. And then there are several additional options to consider, particularly if it's available, belantamab. Certainly alkylators should be kept in mind. We don't use venetoclax except in patients with 11-14 translocation, and that too if you're exhausting other options. Adding panabinostat may be an option. Quadruplet regimens, VDT pace like old chemotherapy regimens may all have a role. Before I close, I want you to remember that there are new treatments coming up. And the most important ones that I'm excited about are CAR Ts, as well as the bispecific antibodies, particularly Amgen 701. Supportive care measures are important, and you could use either zoledronic acid or denosumab for bone prophylaxis. I personally have not used denosumab so far. I prefer zoledronic acid for my patients. It works just as well, and at least for two years. And even every 3 months might be enough. I'll close with smoldering myeloma. As you know, smoldering myeloma is still there. Patients with more than 10% plasma cells and don't have any myeloma defining events. In these patients, the Mayo Clinic group has just published that you can risk stratify them into high risk and low risk using a very simple system, just M-spike, bone marrow plasma cells, and free light chain ratio. If you have 2 risk factors, that group has a 50-50 chance of progressing within 2 years. That means it's no longer 10% per year, but rather 25% per year. In these patients, early therapy with lenalidomide seems to delay progression-free survival, seems to delay progression to end organ damage, as well as prolong overall survival, as shown on this slide with the Spanish PITAMA group trial, as well as in the ECOG trial that we led, where we found a similar improvement in progression-free survival. Again, you can delay end organ damage significantly by using lenalidomide or lenalidomide dexamethasone in high-risk smoldering myeloma. So my algorithm for smoldering myeloma is shown here. If patients have myeloma-defining events, clearly that's myeloma and you treat it as myeloma. If patients have no myeloma-defining events, you risk stratify them using the 20-20 system. And if they have high-risk disease, I recommend therapy with Len or Lendex or enrollment in a clinical trial. However, if they have intermediate or low-risk smoldering myeloma, observation remains the standard of care. I will close my talk with this, and I hope to see you in person.